in addition to being an outstanding clinical chemist, some of you may not realize that Amy is just a fantastic teacher for our medical students. And several years ago, when the medical students were first starting to have lectures and talking about race-based medicine, there was challenging times when the medical students would sometimes interrupt lectures to point out areas of race-based medicine. And one of the specific ones was the use of the estimated glomerular filtration rate and the racial discriminator in the reference ranges. And Amy was fantastic in giving her lectures to the students at that time because she was careful to talk about this from the perspective of what we knew at the time, but she also delved into it greatly and has done significant work in this field of finding alternatives to measure kidney function. And so today I'm really excited that she's going to talk to us about removing race from kidney function estimates and present her work to us as part of the DEI Grand Round. So thanks very much, Amy, for doing this. And I'm really excited to hear your talk today.
Thank you so much, Debbie, for that introduction. So my title today is Removing Race from Kidney Function Estimates. And as Debbie alluded to, I've been involved with this effort, and I'll mention kind of the 2 points where I did get involved specifically in this effort by the nephrology and clinical lab community to make this change. So just a couple of disclosures before I move on to my talk. I am an external consultant for Roche, not related to this presentation, and I have received research support from Siemens and Kyowa Kirin in pharmaceutical development, again, not related to this presentation. So my objectives today, before I dive into kidney disease and how race is involved with kidney function estimates, I want to just broadly define race-based medicine, talk about its consequences, and talk about a few related aspects to why we shouldn't be using race to make medical decisions. I then am going to focus more specifically on the origins and consequences of race-based estimated glomerular filtration rate reporting. I'm then going to move to give you a picture into how we evolved to the current recommendations for the use of EGFR equations without that race parameter. And then lastly, I'm going to spend a couple of slides discussing future approaches to eliminate race-based medicine. So let's first talk more broadly about race-based medicine and its consequences. So race-based medicine is the long-established practice of altering or adjusting medical care based on the race of the patient. And over the last several years, this practice of race-based medicine has been under increased scrutiny. A recent cultural focus on social justice in the US, spurred by the George Floyd murder and other injustices affecting people of color, has heightened calls to enact change to eliminate racial disparities. So I want to give a little bit of history of race and race-based medicine, because I think that provides some important context to the discussion today. So defined race-based groups in scientific literature dates back as far as 1684, with the common theme of race groups being used to create a hierarchical classification system, with whites or Europeans described as a superior group. The introduction of eugenics followed in 1883, with Francis Galton proposing that targeted breeding could provide more suitable races a better chance of prevailing. And throughout the evolution of these concepts was the consistent theme that race and biology were coupled. While eugenics was largely condemned in scientific circles by the 20th century, this practice of linking race and biology remained. And this practice of equating race with biology was really challenged by Dr. Craig Venter and Dr. Francis Collins, who were leaders of the Human Genome Project. So they really brought to light the issues with equating race with biology. So in June 2000, they announced, with many of the announcements that went along with the Human Genome Project, that there was no scientific or genetic basis for the existing race categories that are used. Since that time, there has been increasing criticism of race-based medicine as research has confirmed that it leads to disparities and inequities in healthcare. Again, race-based medicine is rooted in this history that identifies whites as a control group and leads to the notion that other racial groups are inferior by promoting a concept that disease risk is biologically associated with one's race. And biomedical research has largely ignored socioeconomic factors that can contribute to observed differences in race groups. So over the last 20 to 30 years, there have been numerous publications that have highlighted racial inequities in medicine and have talked about the need to eliminate race-based medicine, but these have really failed to gain much traction until recently. And again, 2020 was a real tipping point in terms of amplification of messages highlighting healthcare disparities for people of color, again, with many people pointing to the George Floyd murder as the stimulus for pushing change forward. So a really prominent publication I wanted to highlight was published in June of 2020, and this is a New England Journal of Medicine article. It was a rather damning study entitled "Hidden in Plain Sight: Reconsidering the Use of Race Correction in Clinical Algorithms." And their conclusion was that their comprehensive analysis of race-based medicine demonstrated how race-adjusted clinical algorithms and practice guidelines are designed in a way to direct more attention and resources to white patients than to members of racial and ethnic minorities. So I'm not going to go through all of these examples, but this is just to show you in that paper that there are a lot of examples of clinical guidelines that rely on a race correction. And so I encourage everyone to pull this article and take a look. But just to give a broad sense, this affects a lot of different areas of medicine, not just nephrology. So you can see cardiology is listed, cardiac surgery, nephrology, obstetrics, urology, oncology, endocrinology, pulmonology. So, and this article isn't even comprehensive. There are other areas of medicine that have race-based clinical guidelines, but this gave a real good picture that this is a pervasive problem throughout medicine. So since I think having concrete examples is helpful, I did want to highlight two examples of inequities with race-based medicine. So the first example has to do with blood pressure treatment guidelines. They were written to recommend against use of ACE inhibitor monotherapy in Black patients based on a study showing worse outcomes in Black patients with this approach. However, further research after those guidelines were issued demonstrated that the poorly controlled blood pressure in Black patients was explained by social factors, such as high stress, less physical activity, obesity, and low potassium diets. So it wasn't a biological thing related to the race. Breast cancer, the second example, breast cancer mortality rates in Chicago were significantly higher in Black women compared to white women. Again, the initial report suggested that this was due to biology, due to race. However, future research determined the true cause of the disparity was that the Black women in this study lacked equitable access to mammograms and were diagnosed at later stages. So I'm going to spend the next few slides talking about the complexity of race, why race is a social, not a biological construct. It's not an objective parameter like a weight that you get or a height that you get at a visit. And therefore, because of its subjectivity, its fluidity, because it is a social parameter, it should not be used to adjust medical care. So first of all, as many of you are probably aware, race and ethnicity is a demographics field it's listed in the medical record. A patient's race that's in the medical record can be based on self-identity if the person is asked or assigned by a provider based on the provider's own assessment or assumptions of the patient's race. So just to speak to this, generally speaking, for clinical research studies, a lot of those will be based on self-identity because they're doing interviews of the patients. They'll typically ask patients in clinical research studies. For patients who are seen in clinics, I would say more likely this is going to be based on provider assumptions. If you reflect back on how many times you've gone to the provider, how many times have you been asked about your race, ethnicity? I don't think I've ever been asked once this question. And so oftentimes this is a judgment that's made by someone in the clinic, just based on their own assessment or assumptions. So related to this concept that race is social, not biological, there have been a lot of professional organizations within medicine who come out with statements to this regard. I'm highlighting here American Medical Association is one of the more prominent ones. They issued a policy statement in November of 2020, encouraging characterization of race as a social construct rather than inherent biological traits. They expressed support for ending the practice of using race as a proxy for biology. And as stated by the new AMA policies on this issue, they said race should be instead presented within a socio-ecological model of individual, community, and society to explain how racism and systemic oppression result in racial health disparities. The AMA also recommends that clinicians and researchers focus on genetics and biology, the experience of racism, and social determinants of health when describing risk factors for disease. So this has then led to the question, as there have been many articles discussing this issue of race-based medicine. Should we stop tracking race and ethnicity in medical records and for clinical studies? Should this practice be discontinued? And there was a really good article, again, New England Journal of Medicine has highlighted this issue quite a bit in the last couple of years. So in 2021, they published an article entitled Race and Genetic Ancestry in Medicine, A Time for Reckoning with Racism. And the authors are adamant that race and ethnicity must continue to be tracked. They stated, we believe that it is inappropriate to simply abandon the use of race and ethnicity in biomedical research and clinical practice, since these variables capture important epidemiologic information, including social determinants of health, such as racism and discrimination, socioeconomic position, and environmental exposures. Eliminating the use of race ethnicity or implementing a race ethnicity blind approach could enable inequitable healthcare systems to persist and exacerbate racial, ethnic inequities and health outcomes. Therefore, the call to eliminate race-based medicine relates directly to discontinuing the practice of equating race to biology and discontinuing the practice of altering medical care based solely on race, but maintaining the ability to track race to broaden our understanding of how one's race impacts social determinants of health and one's access to equitable healthcare. So a little bit more on the complexity of race and why it shouldn't be used as an objective parameter for medical care. So first of all, race is more complex than the simplistic categories we have. And I want to talk about the changing demographics in this country and the increases in multiracial individuals. And this slide is particularly pertinent to myself. Some may not be aware, but I myself am biracial. I'm my dad was born in North Korea. I'm half Korean, half white. And so this first bullet point here was particularly surprising to me that it took this long for the Supreme Court to prohibit these interracial marriage laws. So there were 16 states that still had laws banning interracial marriage in 1967. And why that number is surprising to me is my own parents married in 1971. So they got married just 4 years after interracial bans were considered unconstitutional. So they were, frankly, real trailblazers with their interracial marriage. So just a few statistics showing that the number of multiracial individuals is increasing. So in 1980, one paper said that 6.7% of all marriages were interracial. By 2010, that was 15%, and that number continues to increase. Interestingly, we haven't had the best experience with tracking multiracial individuals at the census because it's only been since 2000 that people have even been allowed to check more than one box. So prior to that, multiracial people, such as myself, would have to check to pick one. And this was the case with a lot of government forms. In fact, when my husband and I got married in 2001 and we got the marriage license, it asked for race. And when my husband went to get the license, they said he had to check just one box for each of us. He told the woman at the counter, my wife is biracial, what do I do? And the lady looked up and said, pick one. So he had to just pick, he just checked the Asian box because the lady would not let him check more than one box for me. Now that the ability to check more than one racial category has been added to the census in 2010 to 2020, there was a significant jump in people who identified with more than one racial group that jumped by 276%, reflecting that we are a much more racially diverse society in terms of multiracial individuals. Another thing that has been thought to contribute to more people self-identifying as multiracial is that there has been this highly popular advent of these at-home DNA ancestry tests. So one study indicated that up to 16% of people in the US have done one of these tests. And these tests are revealing previously unknown multiracial identities. And there was a study, there have been some studies that have found that when individuals who have participated in these ancestry tests are find out they do have, more than the races that they initially thought, they are more likely to self-identify as multiracial after receiving their ancestry reports. So as I mentioned earlier, when a provider sees a patient, typically they are not asking the patient, what is your self-identified race? They are assigning a race based on their observations. And so this is my exercise for the day. I have a picture of 2 children, and these children agreed to let me use their pictures today. So I just want you to take a look, and if you were a provider, a pediatrician seeing these children in clinic, what race would you assign these children if you were their provider? So this is just to highlight the pitfalls of assigning race. These are pictures of my beautiful niece, Maddie, and my son, Luke. Both of these children are multiracial, but people will assume Maddie is African-American and Luke is white. Maddie is actually triracial. Her dad is African-American. Her mom is my sister, who's half Korean, half white. So Maddie is half African-American, a quarter Korean, a quarter white. I will tell you, my sister has dealt with all sorts of assumptions about Maddie when she goes out, and with her other children. People ask if her children are adopted because they don't necessarily look like my sister in terms of skin tone. With Luke, my son, who is quarter Korean, 3/4 white, I enrolled him in a Korean culture camp one year. He shows up and the teacher is looking at us funny because I have a blonde-haired, blue-eyed kid with me. So I had to explain, because this camp is intended for people with Korean heritage. I said, my son is in fact a quarter Korean. I know he doesn't necessarily look it from the outside, but the point of this is that people do not always look like the race that you think they are, and you cannot always tell that individuals are multiracial just from appearances. So other things that influence self-identified race. So we might think, okay, let's not assign people race, but let's ask them what their race is, and that's going to be more objective. But even self-identified race has social influences, is subjective, and is fluid. So individuals can have a variety of reasons for their racial self-identity. For example, if a multiracial individual feels they look more like one race than another, they may identify with that race because that is how society sees them. Again, I will use my son as an example. I asked him as I was preparing this talk, when people ask you what race you are, what do you say? And my son said, I just tell them I'm white. And I'm like, I asked him, why don't you tell them you're biracial or that you're part Korean? And he told me, and this is a typical teenage boy thing, he's like, it's too complicated. It's too hard to explain. Because people just see me as white, so I just tell them I'm white. So this brings up the point that self-identity may relate to how people view a person, and then that's what they will say their race is. Racial self-identity can also be related to the family and culture the person grew up with and felt closest to. So here I can tell my own story. I grew up in predominantly white Kansas, but I spent a lot of time with my Korean family. So I felt more attached to that side of my family. I related to that side of my family more. Additionally, predominantly white Kansas, I was, for a while, the only biracial, other than my sisters, the only biracial person I knew for quite a while. So other people looked at me there as Asian because there weren't other Asians around. And so if you were to ask me during my childhood what race I was, I would have self-identified as Asian because that's what made me different there. I was closer to my Korean family. And so that, the culture and the environment where you are can influence your racial self-identity. The next point is that it's fluid. And again, I can use myself as an example, and your self-identity can change. When I went to college in Boston, I was at a school with 30% Asian students. I had been calling myself Asian for 18 years. I go out there and I have, there's 30% Asian students. I suddenly realized that some of those Asian students are looking at me like, why is she saying she's Asian? She doesn't look like she's fully Asian. And so once I got out to Boston, I started to be more clear that I was biracial because some of the Asian kids who were my friends were saying, well, you don't speak Korean fluently, or, you're not really fully Asian. So people were questioning my identity there and based on the culture there. The next point is that people may not realize the extent of their multiracialness. And again, this has come to light as people are doing these genetic ancestry tests and realizing, for example, my African-American brother-in-law, he knew he was descendant of slaves, but he didn't realize that he had X% of, white Ancestry until he did one of those tests. And so a lot of people may not realize the extent of their multiracialness unless they're doing one of these tests. And so the point of this slide is that self-identified race may not reflect genetic ancestry, and the overall point is that race is a social, not biological construct. So now that I've given background on race-based medicine, the subjectivity of race, I want to move into talking about how race has been used to estimate kidney function and talk about the origins of that practice. So first, just a little bit about assessment of kidney function for those who don't have background in this. So the primary means of assessing kidney function is to determine the glomerular filtration rate, or GFR. And this diagram shows this simplistically, that the blood comes into the glomerulus, and then the blood is filtered, and waste products and extra fluid enter the tubule here, and this is eventually excreted into the urine. So the glomerular filtration rate is a measure of this rate of filtration here at the glomerulus. The GFR can be either directly measured or can be estimated. Direct measurement of GFR is performed by measuring the plasma or urinary clearance of an exogenous filtration marker. So ideally, the exogenous filtration marker would be filtered by the glomerulus here, and then not secreted or reabsorbed by the tubules, which is the yellow structure here, because you want the amount that's ultimately in the urine to only reflect the filtration at the glomerulus. Now, direct measurement of GFR is the gold standard for assessing GFR, but it's a very time-intensive and expensive procedure. It takes half a day to perform. It's very complicated to do it right. And so the vast majority of people are never going to have a direct GFR measurement performed on them because of that. And so what we use instead clinically is an estimated GFR. And estimation of GFR is based on a calculation, which there's a variety of calculations, which I'll go into, which incorporate measurement of an endogenous, one or more endogenous filtration markers, endogenous filtration markers such as creatinine or cystatin C. And these formulas incorporate other parameters to provide a final estimate of this glomerular filtration rate. So I wanted to talk about the history of estimating kidney function because that will give some perspective on how the race parameter got incorporated into the equations that we've been using up until recently. So first of all, the history of estimating kidney function started in 1926 when Paul Brandt Rayberg published the first description of glomerular filtration estimation based on creatinine clearance. So he was the first to kind of describe this concept of estimating that glomerular filtration rate. Jump to 9 years later, in 1935, James Shannon and Homer Smith made two important discoveries. First, they actually discovered that creatinine isn't necessarily the best marker for estimating glomerular filtration because it is secreted by that proximal tubule. And so you're going to get extra creatinine in the urine, and creatinine clearance will overestimate your GFR. Additionally, they importantly discovered, they were the first to discover a good exogenous filtration marker that is still in use today, inulin. And they found that inulin is better for estimating GFR than creatinine clearance. Jump ahead about 30 years to the very first eGFR equation that was developed and then put into clinical use. And this equation was developed by Donald Cockcroft and Henry Gault in 1976. They developed the first formula to predict creatinine clearance from a single measurement of serum creatinine. The formula was derived of note from just 249 male patients ages 18 to 92. They tested a small number of women to add a correction factor for female gender, but the way they did that was subsequently criticized as not being a robust way to account for women in their study. Additionally, this cohort was not racially diverse. It was estimated to be about 100% white. This equation, the Cockcroft-Gault equation, included parameters for age, sex, and weight. And it was put into use, and for about 20 years was used. And by the 90s, though, investigators noted that the equation did not perform well in African-American patients. So this is part of the reason why another equation was developed in the 90s, in 1999. The modification of diet and renal disease, or MDRD equation, was developed due to these perceived shortcomings of Cockroft-Gault. Okay, there's a lot of issues with that equation that were criticized. Cohort size, lack of racial diversity, all male. And so the MDRD equation was derived with a much larger cohort, 1,628 patients. 80% were white, but they did recruit 12% African Americans, so there was more diversity in the cohort. And then rather than just a handful of women that were tested, this was 40% female, 60% male. And what they did was they measured the GFR on these participants using an exogenous filtration marker called iothalamate, and they established a formula for estimating the GFR with a one-time serum creatinine measurement. And what they observed in this study, and this is really where the race coefficient or parameter originates from, they observed that African-American patients had a higher measured GFR for a given serum creatinine compared to the non-African-American patients in their cohorts. And so therefore, they incorporated a correction factor for African-American patients into the MDRD formula. And this correction for African-American race essentially increases the GFR estimate by about 20% for a given serum creatinine. Jump ahead to 2009, there was an additional evolution in EGFR equations. The Chronic Kidney Disease Epidemiology Collaboration, or CKDF group. Dr. Andy Levy was the lead on the MDRD equation. He was also one of the lead founders of the CKDF collaboration. So he is involved in development of both of these equations. CKDF involves also Dr. Leslie Inker, so she's been prominently involved in equation development. So they developed a new creatinine-based equation called the CKDF equation. It was developed because it was found to be more accurate than the MDRD equation at higher EGFR. So one of the criticisms of MDRD is that it was not accurate when the EGFRs were higher. This equation retained a correction factor for African-American race, which increased the EGFR by about 16% for a given serum creatinine. And then 2012 marks the last evolution in equations beyond what I'm going to talk about near the end of my talk, which is the 2021 equation. But 2012, the same CKDF group developed new equations that utilized a different biomarker, cystatin C, and they published two equations. The first relied on cystatin C measurement alone and did not include a race parameter, as there were no observed differences in cystatin C levels by race groups. The second equation included both creatinine and cystatin C measurements in the equation. This equation was found to be the most accurate in terms of estimating GFR, but it still included a race correction because of its reliance on creatinine. So I want to explain the rationale. I think I've highlighted it a little bit, but why the race coefficient was included to begin with, and give some perspective on, the thoughts at that time when developing these equations. So at the time of the MDRD equation development, inclusion of a more racially diverse cohort was lauded as an advance in terms of inclusion for research. A big problem with research then, and frankly still even today, is a lot of research studies back then were predominantly Caucasian or white participants, and then guidelines were being made based on white participants and applied to everyone. And so there wasn't a lot of racial diversity in research studies. And so this was something that was viewed as an advancement to actively recruit more diverse cohorts. And so incorporation of the race coefficient at that time was viewed as an attempt to improve and tailor medical care to African Americans. This was justified by a hypothesis that African American individuals release more creatinine into the blood due to a higher muscle mass on average than their non-Hispanic white counterparts. However, in 2008, Sue et al. Set forth to examine this hypothesis rigorously, because the studies done up to that time were really not very rigorously done. So they looked at whether body composition and specifically muscle mass or nutritional status explained the differences in serum creatinine between African American and non-African American individuals. And they found no evidence that muscle mass or nutritional status explain these differences. So why is this important? Why do we care that we were reporting different EGFRs for African American patients versus non-African American patients? Well, there's a lot of clinical conditions where assessment of EGFR is critical or important. And this table gives a list of those. And first and foremost, EGFR is what is used to diagnose, stage, and follow patients with chronic kidney disease. And this is shown with this heat map diagram here. These are the categories of chronic kidney disease, and you can see that EGFR is how one is categorized along with albuminuria. And so having an accurate EGFR estimate is important for accurate diagnosis, and having a race correction factor would give an African-American patient a different EGFR than a non-African-American patient. EGFR is also used for things like evaluating patients for kidney donation, assessing risks or prognosis, dosing and monitoring medications, determining the safety of certain diagnostic tests or procedures, referrals to nephrologists. A lot of guidelines will have cutoffs, EGFR cutoffs for when to refer a patient, when to refer them for transplant, whether or not to do placement for dialysis access. So a lot of really key clinical decisions are being made based on EGFR. And then change in EGFR is also important for detection of acute kidney injury, progression of chronic kidney disease, risk for kidney failure, et cetera. So this is an important clinical tool. And so this can really impact our patients. So this then leads me to explaining the disparities in care that have been observed, specifically for African-American patients. So African-Americans have been noted to have declines in EGFR at an earlier age and at a faster annualized rate than non-Hispanic white Americans. African-Americans develop advanced kidney disease at younger ages, with an incidence of end-stage kidney disease about 3 times their non-Hispanic white counterparts. Studies demonstrate that despite this, African Americans are more likely to receive a late referral to nephrology and less likely to be treated with home dialysis therapies. African Americans are also less likely to be waitlisted for kidney transplant and are transplanted at a lower rate than their non-Hispanic white counterparts. And if you think about it, these disparities are compounded by the use of race to estimate GFR, because the current formulas increase the estimated GFR for African American patients only for a given creatinine. So the equations will make an African American patient's EGFR appear better than their non-African American counterparts. So this then leads to the last part of my talk. And I want to talk about the process of removing race from GFR estimating equations, how that process evolved. And this is something that I was directly involved with. So I'll highlight those points where I was involved, but it was very interesting for me to see how this process played out over the last couple of years. So first of all, there was really kind of a groundswell of support for the removal of race from GFR estimating equations that started, many attribute it to starting with medical students. And Dr. Powell mentioned this. I was asked questions about race-based medicine starting several years ago. At other institutions, they've reported that students really are the ones who began questioning this practice during medical school lectures and began to call for the removal of race from EGFR equations. So this is not something new. This is something that has been criticized for a while, but it's only recently that there's really been movement. So in 2019, both JAMA and the Clinical Journal of the American Society of Nephrology published prominent editorials criticizing the use of race in kidney function estimation. By the end of 2019 and early 2020, there had already been several prominent academic institutions that had adjusted their EGFR reporting to remove reporting based on race. And those academic institutions are listed here. So there was kind of this slow roll of movement on this issue. And again, the murder of George Floyd in May 2020 really brought forth heightened cries to enact meaningful change to race-based medicine practices to eliminate healthcare disparities. That New England Journal of Medicine article I talked about earlier that looked critically at all of the different race-based guidelines, that was published in June of 2020. That really was the final push needed for the nephrology community to take action. So that article has been cited as kind of the final push for them to actively do something about this. And so what that was in the summer of 2020, there was a partnership formed between the National Kidney Foundation and the American Society of Nephrology. They announced the formation of a task force that was going to critically examine the use of race in GFR estimating equations. They set forth to examine every aspect of the inclusion of race in these calculations, recognizing that changes in reporting must consider multiple social and clinical implications. They resolved to make recommendations based on rigorous science and be transparent to the public, clinicians, laboratorians, and other public health officials in regards to potential long-term implications of their recommendations. So this is just a slide showing, I'm not going to go through all this, but in bold are the people who are on the task force, and they each led a topic, and they were moderators for a topic of discussion the panel addressed. And you can see this covered things from the history of GFR to measurement, estimation, of performance in the US, race and racism, body composition, laboratory standardization, patients' perspectives, and then possible approaches. So this is the first place where I was involved. I was invited, you can see here my name, although they got my middle initial wrong, but I was invited to speak to the task force under the laboratory topic. I specifically talked about cystatin C as an alternative marker because, as I mentioned earlier, the cystatin C equations do not use race as a parameter. There's no observed differences in race groups with cystatin C. But you can see that the task force invited a lot of speakers with a lot of varied areas of expertise. And this task force included not only nephrologists, but laboratorians. Dr. Greg Miller, who many of you may know is a prominent clinical chemist. He was on the task force representing the lab. It include patients to get their perspective. It include people who had expertise in race-based medicine, racism issues. So at the same time, this is another area where I was involved. There were parallel efforts by the Ckdf research group. So I currently direct the central lab for the CKD group. This is something that Dr. John Eckfeldt did for many years and then passed on to me a few years ago. And so I, along with Dr. Siegmiller as well, am involved with the Ckdf research group and doing testing for this research group. So in July of 2020, the leads of the Ckdf group, Dr. Andy Levy and Leslie Inker, reached out to many of us who were involved with their research and said they were going to reevaluate the existing creatinine-based Ckdf equations because they were well aware of what the task force was setting out to do. They kind of saw the writing on the wall that there needed to be a change. Dr. Inker, if you noted, was also on the task force, the NKF-ASN task force. So she was intimately aware of what was going on in the task force with the discussions. And so they set forth to re-examine the race-based equations that they had developed. And what they did was the pooled cohort data used to derive those equations were reanalyzed. So they took the same data that they used to develop the race-based equations, they pooled it. So this time, instead of separating Black and non-Black participants, they grouped them all together to derive a single equation. And this new creatinine-based Ckdf equations were then validated using a new data set that combined cohort data from old studies, and then they incorporated some new studies as well. So they, just to get their numbers up to have better power, excuse me. And so this is what they set out to do also in the summer of 2020, around the time that the task force was being assembled. So before the task force could issue their recommendations, I just wanted to highlight that there was still a lot of movement on this issue. Unfortunately, this did lead to a lot of non-standardized approaches that were adopted before the official guidelines were released. And I just wanted to highlight those. So that between 2019 and late 2021, many academic and clinical institutions just went ahead and moved forward with removing race from GFR estimates prior to the impending NKF-ASN task force guidance. While the intent of the removal of race was good, there were concerns about the lack of a standardized guideline-based approach. And so basically what was happening was that each institution, because there were no guidelines yet, each institution was just taking their own approach, having convening committees and deciding how to tackle this. The most common approach taken was to report a single eGFR based on the non-Black equation and discontinue use of the race correction factor. And while this seems like a good solution on the surface, the issue with this approach is that the non-Black equation was derived from a cohort that specifically excluded Black individuals. So it was in effect applying an equation for predominantly white people onto Black individuals. So this is kind of harkening back to the original problem with Cockcroft-Gault, right? That study was in all white individuals and you're applying it to everyone else. And so even though this was the most common approach, I think a lot of people said, this is really not what we want to have as a long-term solution here. Another approach, which was interesting, but also criticized, was to report a range, with the lower end being the eGFR using the non-Black equation, the upper end using the Black equation. And different labs reported these ranges differently. Some just called them high and low. Others said low muscle mass, high muscle mass. This was considered non-ideal because the clinician would not know which number to pick. They may wrongly assume they should pick a number in the middle. It still utilized the race correction factor that many felt should not be used, regardless of what you call it. So this is kind of what was going on in the background as the task force was working, as the Ckdf group was working. So in the end, so those task force and the Ckdf group started their work in mid-2020. By 2021, the task force had come to some conclusions. So they deliberated. It took a while to assemble the task force, and then they had 10 months of deliberation. So they really started meeting in December, around December of 2020, and then they deliberated and then were able to make their publication in September. So they determined that the best approach moving forward was derivation of a single GFR estimating equation derived from a racially diverse cohort to be used for all patients. The NKF ASN task force was aware, of course, of the parallel work by the Ckdf research group to derive such an equation. And as I mentioned, Dr. Leslie Inger was part of both the Ckdf group and the task force. And so therefore, they worked together. So the Ckdf group expedited their analyses and publication of a new equation. This is called the 2021 Ckdf creatinine equations, such that the NKF ASN task force final report could directly recommend immediate implementation of their new 2021 Ckdf equations. And it was really quite slick. There was a flurry of emails prior to this where Leslie was trying to get us to, get the article in shape so that everything could be issued. And in fact, both the task force guidelines and the New England Journal of Medicine paper with the new equations were published on exactly the same day online. So they were really excellent about getting the timing right in this and issuing both of these simultaneously. So just to highlight what those final recommendations were that were issued by the task force. So their primary recommendation was that there should be immediate implementation of the 2021 Ckdf creatinine equation refit without the race variable for all clinical laboratories in the United States. Their rationale for this approach is that it does not include race. It includes diversity in its development. So again, they pooled the data that included both Black and non-Black participants into one cohort, and it was racially diverse. This approach is immediately available to all labs in the US. Now, this is a point because they did consider and discuss other biomarkers to use, such as cystatin C, but cystatin C is a send-out test in over 90% of labs. So it was viewed as not being really immediately practically available to use, even though it doesn't have that race parameter in its equation. So that was a consideration for this recommendation as well. And then also this equation in the New England Journal of Medicine paper has acceptable performance characteristics. In other words, it performs accurately enough that it's acceptable for use in all individuals. Their second recommendation, they didn't want to completely drop cystatin C. So they were very excited about cystatin C. And so they did recommend national efforts to facilitate increased routine and timely use of cystatin C, especially to confirm eGFR based on creatinine alone, because the cystatin C equations have never had a race parameter. So again, the rationale, because it doesn't have observed differences between race groups, and therefore it's never had a race parameter. So this is what I just said. And additionally, studies have demonstrated that using both creatinine and cystatin C to estimate GFR provides the most accurate estimate. And so there's really a push to use cystatin C more in these guidelines. And that's something that we are pushing for in general with our providers. Number three, their final recommendation is that research on GFR estimation with new endogenous filtration markers and on interventions to eliminate race and ethnic disparities should be encouraged and funded. So the rationale here, newer approaches are needed to generate accurate, unbiased, and precise approaches to GFR measurement that are not reliant on race and which promote equitable care. So I'm going to wrap up my talk with just a couple of slides on future approaches to eliminate race-based medicine. So just to give a big picture on what's happening now in the field of and discussion on race-based medicine. So there continue to be numerous editorials published in medical journals in a broadening number of fields on this topic. And those are helpful because it provides education to medical providers and provides support for enacting change. So if you go to PubMed and you put in the term race-based medicine, you're going to find a lot of articles, particularly more recently. Outside of nephrology, there have been other specialty areas that have made concrete changes to guidelines or clinical practice recommendations. Here's just one example. The American Academy of Pediatrics recently retired a guidance on urinary tract infections that included the improper use of race as a factor in disease risk. Other specialty areas have editorials calling for removal of race-based guidelines, but changes have not yet been enacted. So for one example, a recent editorial examining clinical recommendations in gastroenterology highlighted the use of race in numerous clinical guidelines and called for removal of race from the guidelines, but it hasn't been done yet. So this is still an evolving area and issue, but nephrology has kind of provided an example of how to tackle this issue with the task force formation. So I anticipate that there may be more task force being formed with other medical specialty areas in the future to address this issue. So lastly, additional research is needed. So the biological basis for observed differences in measured GFR for a given serum creatinine between self-identified African-American and white cohorts in these research studies has not been elucidated. We still don't know why we see those differences. Research is needed to identify the factors responsible so that we can more accurately estimate GFR and understand the why, rather than using race as a surrogate for this. Future studies involving the development and or validation of EGFR equations must be more intentional about recruitment beyond predominantly white and African-American participants. So you'll notice that I've been talking almost entirely about these two groups, but there are, of course, many, many other ethnic minorities that have been largely ignored in these studies on kidney function and EGFR equations. And so if we want to have a truly diverse cohort reflective of our population, we need to be better about recruiting beyond just these two groups. And then lastly, large clinical trials and population-based studies should improve recruitment of diverse populations, and any observed differences between racial and ethnic groups should be further investigated to determine the biological basis. So this is, I think, then the main problem in how race-based medicine has become so firmly rooted. When we have so much epidemiological data out there with these large cohort studies, and there's all these studies where you see differences in races, and that's where researchers have stopped. They've just said there's a difference between this race group and that race group, end of story. And really, we need to go beyond that. We need to figure out the why of why there's differences, because clearly it's not just because of race. Race is a social construct, not a biological construct. It's not a biological reason for differences. And so we need to be more rigorous in figuring out why there are differences when we see them in research studies between race groups. Here are my references on this slide, and then I will take any questions. Here's a picture of my lovely multiracial family. You can see my dad and my mom here and my sisters. Here's me, sister, and then the rest of my nieces and nephews and brother-in-laws. I will take any questions.
Thank you. That was wonderful. I just wanted to break in and ask one question, which is, how do you think we're going to be able to overcome the decades of discrimination in other ways that have made it harder to get different racial groups to participate in studies like this? Because the creation of study sets that really look at the diversity of America is so important, but how are we going to overcome this decades of problems?
Yeah, I mean, that's a great question. And I will say we're struggling with that ourselves with our Serum vaccine response study. We're just not getting a good representation of racial and ethnic diversity in our study either. You know, I will say that a lot of studies, and SeroNet included, are including patient representatives and people who have expertise. Like there's actually a group, I think it's out at UMass, that's part of SeroNet, that's specifically looking at reaching out to underrepresented groups and people who have been disenchanted with medical, you know, the medical establishment and strategies. So I think there's going to be a lot more publications on strategies and approaches that can be used to reach out to these communities that are disenchanted and may not readily volunteer. And yes, I completely agree with what Michelle's saying. Having more African Americans involved in leading studies, right? Having better representation in the people who are actually the faces of the studies is another aspect. But this is definitely an active area of discussion and how to do a better job of getting a more diverse cohorts into research studies.
We've got Chris, and then we've got Leo, and then we've got John.
Thanks, Amy. That was great. I'm just wondering how difficult or challenging would it be for clinical trials and other types of studies to strategize patients by their access to healthcare or time to accurate diagnosis or something that does have a more meaningful biological basis?
Yeah, no, that's a great question. I mean, there's a couple things. One is we need to start collecting that data, looking more at social factors. A lot of times they're not even collecting that data necessarily. And so I think that's something that needs to be standardized and better understood is what types of factors should we be looking at in terms of socioeconomic factors that can impact health, and do a good job about collecting that data. And again, this is really an evolving thing.
And I guess it won't happen until NIH mandates it, right? Like
yeah,
it did for
and
children
NIH
and sex
is,
and race.
Yeah, and NIH is, they are issuing more proposals that are asking for a focus on reaching out to underrepresented groups and things like this. So I think there are efforts now to try to be more proactive in this area, but it's going to be a long process, I think, to get to where we want to be.
Leo?
Yes, thanks, Deb. That was wonderful talk, Amy. Thank you for all the great work you and others are doing on this. It's very, very important work. So I wonder what your thoughts, or maybe some of our other gene-related people on the Zoom might think about maybe a way to do away with these, what are obviously arbitrary social constructs of race. Is what if, with massive amounts of data over time, we develop polygenic risk rules that would lead us to understand this group of patients, regardless of race, are going to have more kidney problems or something like that. I wonder what your thinking is about that.
Yeah, no, I totally agree. And I think that's where a lot of the editorials are saying we need to be more rigorous about figuring out the actual genetic basis or socioeconomic factors. It's going to be a combination, but I think the goal ultimately, right, is personalized medicine. I think we increasingly realize that each individual patient is different and unique, and applying these kind of general categories to people is not, in the best interest of the patient. And so we need to really find out the biological basis for these differences that we observe, rather than just kind of stopping and just saying, oh, it's race, when really there's something behind that. There's either a genetic factor or there's some environmental factors. And that's where I think we need to go with research to be able to have a more accurate treatment plan for each individual patient. So I completely agree that a more personalized medicine approach and having genetic information on patients would be ideal with some of these things.
Thanks very much.
John?
Yeah, Amy, thanks so much. I really appreciated this talk. I was on a meeting last night where we all were talking about how we can get universal single-payer health care both in this country and in this state. And we think of some of the African Americans as having perhaps a higher incidence of cardiac disease, but it really is a completely a social determinant of their ability to get health care. Because what I heard last night in one of these meetings was that, in fact, Blacks who go to the VA for their health care and thus can get health care about equally to whites have actually less incidence of cardiac disease than whites do, which was really fascinating to me. And I also wanted to make, two comments. One, when I was in medical school, I was in medical school in St. Louis, and the entire medical system was completely segregated. There was absolutely no overlap between whites and Blacks in the medical system. Everything was completely segregated. This actually didn't change until 1965, when Lyndon Johnson signed the Medicare bill, and he insisted that this segregation which was primarily in the South, be eliminated, or else they wouldn't get Medicare money. So that was really interesting. And to comment on Leo's comments, we do know that the lipoprotein genetics is very important in Blacks getting hypertension and cardiac disease. And it's very clear that the group of Blacks who grew up in Africa or have an African heritage and developed this mutation in order to avoid getting leishmaniasis. This comes with an increase in renal disease. So this gets exactly at Leo's comments about personalized medicine. So anyway, thank you so much. That was a wonderful talk.
Yeah, and thank you for your comments, John. I think those are all really good points.
Yeah, Amy.
Yeah.
John Eckfeld. Great talk. Really, really enjoyed it, and an excellent review of the history. I have one comment and one question. The comment is, I think everybody should understand that these are estimates, and really, in some ways, not very good estimates. There are criteria for acceptability is that 90% of the values of the measured GFR have to be within 30% of the estimated GFR. So they're sort of very rough estimates that, they're really not great in many ways. The question I have is, the original Black versus non-Black was driven by the data, the self-reported values. It wasn't that they had a preconceived notion. If they looked at the data of self-reported. So why do you think there was a difference? And you're right that it seems to me it has to be either something in the filtration mechanism in the kidney. It has to be something in the production of creatinine in the body for whatever reason, skeletal mass, or it could be diet. I mean, meat has a lot of creatine that's converted to creatinine in cooking. So why do you think it was different in the original data set that they took out then when they developed the new equation?
Yeah, no, that's a great question, and that's the problem is nobody has figured that out yet. And I think that it's kind of been, we've been saying it's muscle mass for all these years, and then there was that study that showed it wasn't. They measured muscle mass in participants and showed it wasn't directly related to the muscle mass itself. But clearly there's something behind it. We see, as you said, there is an observed difference in those studies, in multiple studies that have looked at a self-identified African-American cohort and a self-identified, white cohort or non-African-American cohorts. But we don't know the why. So I think that's what a lot of these recent papers have been saying is we need to go back to looking at actually understanding it versus just attributing it loosely to race, which is really kind of a lazy thing to do scientifically, given all these issues with race as a social categorization. We need to get to the fundamentals of why are we seeing this. If it is something genetic, then, at some point that could be something that could be tested for. And then we could more accurately estimate GFR based on the genetic factor that's impacting creatinine levels in individuals. But I think at this point, we don't know. So this is kind of, and as you said, eGFR is not a very accurate thing to begin with. And unfortunately, it's been applied to all these clinical guidelines as if it is highly accurate. And it is widely used. But that's definitely an important point as well. Bharat, I see your hand up also.
Yeah, thanks.
Okay.
So this was a great talk, Amy. And I just wanted to follow up on, John's comment about, the approach. While I completely agree that the racial categories or social constructs are rather arbitrary, and there are good social reasons to get rid of the race-based equations. But the approach that the nephrology community has taken seems to be like reanalysis of the data rather than coming up and actually fixing the problems with using serum creatinine as a measure of estimated GFR. And I was I was just wondering why, there is not a bigger push to just move to a cystatin C-based EGFR measurement by the lab community.
Yeah.
Because that seems to be race independent.
Yes.
And maybe a better marker.
So completely agree. If cystatin C was more widely available, I think that would have been the recommendation. So there's a couple of reasons why this is kind of even though this is a final recommendation, many of us view this as kind of one step in a process that needs to continue to move forward. The reason the task force felt like it was important to give guidelines now, even though things are not in a perfect state and there's a lot of problems with their current recommendations, that all these different labs are doing different things. Like I mentioned earlier, some were just dropping the Black correction factor and using the equation that was meant for non-Black people that didn't include any Black people in the cohort. Other people were doing the range. So there was all this non-standardization, and the nephrology leaders were not happy with that. They really strongly feel that EGFR needed to be reported in a standardized fashion. So that's why they said, this is the best. This is the best we can do at this moment. Cystatin C is definitely going to be a big focus. The problem right now today, though, and this is part of the talk I gave the task force, it is not being done in most labs right now.